Good morning, consultants, senior residents, my fellow residents, MOs, medical officers. I am going to be presenting management of Epistaxis today. I'm Zuweira Umar. Next. Oh, this one. I'm going to be using the following outline: introduction, epidemiology, blood supply to the nose, common bleeding sites, causes of epistaxis, management. I'm going to talk briefly on the role of the family physician, conclusion, and my references. By way of introduction, introduction. Epistaxis is a medical term for nosebleeds, defined as spontaneous or induced acute hemorrhage from the nostrils, the nasal cavity or nasopharynx. It's a frequent complaint emergency units and GOP, family medicine practice, often causing significant anxiety in both patients and clinicians. It's estimated around 90% of cases presenting in the accident and emergency can be treated successfully by emergency physicians. Lifelong incidence in general population is around 60%, between 10 to 15% prevalence in Europe and North America. It has a bimodal peak presentation, between 2 to 10 years and then 50 to 80 years. Said to be commoner in males than females. Most cases of epistaxis are self-limiting and unreported, so the true prevalence is unknown. Could vary between 10 to 12%. Rarely, massive bleeding could result in death. It's estimated that 4 out of 2.4 million deaths in the United States are from nosebleeds. Okay. The nasal cavity, the septum and lateral walls are supplied by both the external and internal carotid artery systems. The anterior and posterior ethmoidal branches of the ophthalmic artery, which originate from the internal carotid artery, supply the nasal septum and lateral walls. The external carotid system supplies the nasal septum, including the sphenopalatine artery, septal branch of greater palatine artery, and septal branch of superior labral artery. Epistaxis is broadly classified into anterior and posterior. The anterior is more common, uh, less serious. The posterior is less common, but it tends to be more severe. Okay. Classification into anterior and posterior epistaxis goes a long way in determining, provides a useful basis for management essentially. In anterior epistaxis, blood flows out from the front of the nose, usually with the patient in the sitting position. Posterior epistaxis, the blood flows back into the throat, so the patient may swallow it and have dark colored or coffee colored vomitus, which may erroneously be diagnosed as hematemesis. So bleeding from the anterior bleeding is commonly occurs in what is termed the litus area, which is situated in the anterior inferior part of the nasal septum, just above the vestibule. This is also this is where the Kisselbach's plexus is formed. The Kisselbach's plexus is where vessels from both the internal and the external carotid arteries converge. Is a usual site of epistaxis in children and young adults, typically less severe, like I said earlier. Bleeding tends to ooze rather than pump profusely, occurs more in dry and low humidity weather, leading to increased chances of bleeding. This area is also exposed to fingernail trauma, essentially picking, nose picking, which could predispose to nosebleeds. Anterior bleeding may also originate anterior to the inferior turbinate. Posterior bleeding is less common, occurs in around 5 to 10% of cases, in an area known as the Woodruff's plexus. Commoner in the older population, the bleeding is profuse, prolonged, and more difficult to control, usually associated with bleeding from both nostrils, greater flow of blood into the mouth and throat, greater risk of airway compromise and aspiration of blood. The blood vessels have very little muscle tissue within their walls, therefore hemostasis is poor. Woodruff's area is a vascular area situated under the posterior end of the inferior turbinate, where sphenopalatine artery anastomosis with posterior ethmoidal artery. Let's see. Okay, causes of epistaxis. So causes could be classified broadly into local and systemic. Local causes include digital manipulation, trauma, foreign bodies, could have intranasal neoplasms or polyps, irritants like cigarette smoke, medications, e.g. topical corticosteroids, in cases of rhinitis or sinusitis, both acute or chronic, septal deviation or perforation, adenoids, vascular malformations, chronic nasal cannula use, or rhinoplasty. Systemic causes could include hemophilia, hypertension, leukemia, liver diseases such as cirrhosis, factor deficiencies, medications such as aspirin, anticoagulants, platelet dysfunction and thrombocytopenia, in diabetes, pregnancy, and others. Management principles. Although most patients can be treated as outpatients, hospital admission and close observation should be considered for elderly patients and also patients with posterior bleeding or coagulopathy. Admission may also be prudent for patients with complicating comorbid conditions such as severe hypertension, ischemic heart disease, or and some anemia. Okay. So usually it's prudent to control bleeding first before taking a detailed history. So it's mode of onset could be spontaneous or traumatic. Yeah, yeah, okay. So to ask about duration, severity, amount and frequency of bleeding, history of previous bleeds, hypertension or other systemic disorders, and laterality of bleeding. If the bleeding is from one nostril or both, preceding factors, exercise, sleep trauma, bleeding tendencies in patients or a family history of such, family history of epistaxis, easy bruising or prolonged bleeding after minor surgery, history of drug intake such as aspirin, anticoagulants, or NSAIDs, alcohol use, physical examination. So it's also important to have proper personal protective equipment and prepare a proper equipment before beginning the physical examination. This equipment may include nasal speculum, headlamps, packing, silver nitrate swabs, cotton pledgets, topical vasoconstrictors, and aesthetics. The examination should be performed under a well lighted room. The patient should be seated and clothing protected by a sheet or gown. The skin should be examined for evidences of bruises, petechiae that may indicate an underlying hematological disorder. Vital signs are very important: pulse rate, blood pressure, respiratory rate, temperature. Okay, so a thorough and methodical examination of the nasal cavity should be performed. Topical application of vasoconstrictor or local anesthetic um, may help to reduce the bleeding. Uh, Gently insert a nasal speculum, spread the nails vertically to expose anterior bleeding sources. Clots and foreign bodies in the anterior nasal cavity may be removed with a small suction tip, irrigation forceps, and cotton tipped applicators. Posterior bleeding usually cannot be visualized with an anterior source, but sometimes blood could be seen dripping in the posterior pharynx. Fiber optic endoscopy allows endoscopic suction and cauterization to inspect the entire nasal cavity, including the nasal pharynx. Important investigations include hematological, such as full blood count with differential clotting profile, biochemical, blood glucose, urea electric, blood urea, liver function test, radiological investigations such as X-ray of sinuses, CT scan and MRI, foreign bodies, um, rhinosinusitis and neoplasm. We could do a nasopharyngoscopy for suspected tumors. So treatment will depend on the clinical picture, the experience of the treating clinician, and the availability of ancillary services. Like I said earlier, it's important to control the bleeding at presentation. So first aid, primary survey, survey airway, hemodynamics, survey for hemodynamic stability. Pinching the nose with thumb and index finger for about 10 minutes to compress the litmus area helps. Cold compresses can also be applied to the nose to cause reflex vasoconstriction. Trotter's method is a method in which the patient is made to sit leaning a little forward over a basin to spit out any blood and breathe quietly into the mouth. Topical vasoconstrictors or local anesthetic. So in this case, cotton ball is soaked in a mix of 2% lidocaine and 1 in 1,000 ratio epinephrine and put in a bleeding nostril for 10 minutes. All clots should be removed before attempt at treatment. This is just a picture of Trotter's method. Okay, so if all the previously mentioned methods are ineffective, cauterization could be done. This could be either chemical using silver nitrate or electrical using hot wire or bipolar culture. Useful in anterior epistaxis when bleeding point has been located. The area is anesthetized and then the bleeding point is cauterized with a bead of silver nitrate or coagulated with electrocautery. Uh, Nasal spray and antibiotic ointment afterwards to avoid strenuous activities for 7 to 10 days. NSAIDs and digital manipulation of the nose should be avoided. Later instructions are given to the patient after control of bleeding. This is a diagram of silver nitrate used for chemical culture, electroculture. Okay, a diagram showing anterior bleeding from the anterior part of the nose, the Kesselbach's plexus. Posterior bleed. Nasal packing. Nasal packing is the placement of an intranasal device that applies constant local pressure to the nasal septum. This works by direct pressure, reduction of mucosal irritation, and clot formation around the source of bleeding. It is indicated in overt bleeding or bleeding after direct pressure, topical agents, or silver nitrate cauterization. All right, so packing could be anterior or posterior. So in anterior nasal packing, ribbon gauze is soaked with liquid paraffin or petroleum jelly gauze filled with antibiotic ointment. Uh, with the use of bayonet forceps and a nasal speculum, the gauze is placed in a layered pattern, packing it from anterior to posterior. The gauze should be placed as far posteriorly as possible to provide adequate pressure. The pack ideally should be removed after 24 hours if bleeding has stopped. But all packings should not exceed 3 to 4 days. For patients with coagulation disorders, absorbable materials such as Surgicel, gel foam, or Avitin can be used instead to prevent trauma on removal. And prophylactic antibiotic cover is indicated to prevent sinus infection and staphylococcal toxic shock syndrome. Okay, a picture of an anterior nasal packing. Posterior nasal packing. A posterior pack is placed to occlude the choanal arc. Indications include failure of the anterior pack, high suspicion of posterior bleeding, and in patients with bleeding diastasis. Bilateral bleed. In, bi- in cases of bilateral bleeds, like I said, look for posterior sources. Posterior pack can be accomplished with gauze, Foley's catheter, nasal sponge or tampon, or inflatable nasal balloon catheter. Regardless of the type of posterior pack used, an anterior pack should also be placed. Contralateral nasal pack is strongly encouraged. All patients with posterior bleed should be admitted for oxygen, fluid status, pain control. Materials required include epinephrine, gloves, tongue depressors, tape, nasal speculum. Posterior packing is uncomfortable and so requires sedation. Prophylactic antibiotic is also indicated here, and then patients should be referred to ENT surgeons for further treatment. Contraindications to posterior nasal packing include facial trauma, shock, or altered mental status. Okay, this is a picture of a posterior pack. Balloon catheter, nasal tampons, okay, endoscopic cautery. A posterior bleeding point can sometimes be better located with an endoscope. Can be coagulated with suction cautery, and then local anesthesia with sedation may be required. Ligation of vessels. The choice will depend on the location of the bleed. In general, the closer the ligation is to the bleeding site, the more effective the procedure tends to be. Okay. All right. This is just role of the family physician. Right. So a lot of the time, the family physician is the first contact care. So it's important for one to be able to manage a patient that presents with bleeding, with nosebleeds, and then to refer if that is necessary. Researcher, advocate. It's also important for the family physician to follow up on management of said patients, even when they have referred, then find out better or newer methods to better manage the condition. Patient education and counseling afterwards, and especially if the patient has risk factors that predispose them to nosebleeds. Continuation of care, follow up afterwards, like I said. Okay. Patient education include sneezing with the mouth open, avoidance of nasal digital manipulation, avoid hot and spicy foods, avoid taking hot showers, avoid NSAIDs and aspirin, avoid hard nose blowing or sneezing, and use of nasal saline spray to essentially prevent dry mucous membranes. Complications of treatment could include synechial and septal perforation for cauterization. In case of anterior nasal packing, synechial as well, rhinosinusitis, toxic shock syndrome, mucosal pressure necrosis, vasovagal episodes, external nasal deformity, balloon migration. Differential diagnosis could include trauma or barotrauma, disseminated intravascular coagulopathy, foreign body in the nose, hemophilia, rhinitis or sinusitis, cocaine toxicity, drugs such as heparin or warfarin, hepatic failure. Prevention of epistaxis. Patients should avoid strenuous activities such as use of helmets or face pieces, hot and dry environments. So the patient should we should encourage use of humidifiers, saline sprays, antibiotic ointments in the littles area, avoidance of hot and spicy food, digital trauma such as nose picking in children and some adults, also keeping the nails well trimmed, nose blowing and excessive sneezing. So instruct patients to sneeze gently into the with the mouth open. Inappropriate or careless use of drugs such as NSAIDs. In conclusion, epistaxis is a symptom and not a disease, and often presents as an emergency. In most cases, it is self-limiting and unreported. Family physicians should be highly knowledgeable in the management of epistaxis, as this could be a key to discovering other systemic diseases the index patient and other members of the family may have. Okay, thank you.